Welcome and thank you for joining. My name is Melanie Betancourt, and I am a health educator for community health at Atlantic Health System. Today's webinar, Cancer and Genetics from Family History to Prevention, is presented by Jessica. Before we begin, I have a few announcements. Okay. This webinar will be recorded. All participants are muted. If you have a question, please use the Q&A button and also the chat feature for comments. We will try to get through all the questions at the end of the presentation, so no worries. And are you or a loved one interested in smoking cessation? Atlantic Health System offers a free quit smoking program. This program includes an individual assessment, free nicotine replacement products, and 6 weekly group meetings to help you quit and stay smoke-free. There are multiple dates and times available, with group available in person or virtually. For more information about these groups and other resources, or for additional dates and times, please call 1-844-472-8499. Now, I'm going to turn it over to Jessica. So I'm going to stop sharing.
Okay, my name is Jessica Heinzman. I'm a licensed certified genetic counselor here at Atlantic Health. I've been here for roughly around 10 years. So I'm going to talk about cancer genetic counseling and cancer genetic testing, really focusing on red flags, things to look for in your family history, things to talk to your healthcare providers about to see if you may be a good referral for genetic counseling and testing. So when most people are diagnosed with cancer or they have a family history of cancer, I find one of the biggest questions is why? Why did it happen? Was it something I did? Was it some exposure? Really, it comes down to most cases of cancer, we don't have an explanation why it happened. It's a very small portion of cancer that's truly hereditary, meaning there's a single genetic change passed down from generation to generation. On average, for our common types of cancers like breast and colon, it's about 5 to 10% of cases. So that means, again, majority of the time, we may not be able to give the patient and their family an explanation as to why it happened. There's also a portion of cancer that can be familial, meaning this is a mix between possibly low risk genetic factors as well as environmental factors. So families tend to eat the same types of foods, have the same tendency towards exercise, live in the same households. So sometimes it's just a combination of multiple shared factors. What we're going to focus on today is this small portion, the hereditary type. So our overall personal cancer risk is a combination of lots of different factors. Some of them we can modify ourselves, such as lifestyle, exercise, what we eat. Some of them we can't change about ourselves, and that could be family history, age we know is a risk factor, as well as genetics. So it's all a combination that could give us our overall risk. So when do we suspect that cancer could be running in the family? Well, we tend to see multiple relatives with cancer, and it's important to note on the same side of the family. So if you have an aunt on mom's side and a grandmother on dad's side, that doesn't equate into a higher risk family. It needs to be on the same side. The earlier that cancer is diagnosed, it's more likely that it could be genetic. However, this isn't the case for all types of cancers, and we'll get into this in more detail, but types like ovarian cancer, pancreatic cancer, some cases the age doesn't matter, it's just the rarity of the cancer itself. A family history of bilateral or multiple primary tumors or cancers can be a red flag. Also, when we see rare cancers in the family. But it's important to note that hereditary cancer often isn't this hodgepodge mix in the family. It tends to be very specific cancers that are inherited with each other. So for example, breast and ovarian, breast and prostate cancer, a lot of times they go hand in hand from a genetic standpoint. We also can see colon cancer associated with uterine or ovarian cancer. So again, it's not a random mix, tends to be very specific cancers that are genetically linked to each other. We also see autosomal dominant transmission, meaning that we expect cancer in every generation of the family. This isn't always the case because if we find someone has a genetic risk, it's not 100% chance that they're going to develop cancer. So there are going to be some family members that for reasons we don't know may slip through the cracks and may not develop a cancer, but then pass something down to their children. We also know that every ethnic group can have a hereditary risk for cancer, but certain ethnicities can be at higher risk than others, and that's in particular the Ashkenazi Jewish or Eastern European Jewish. So when we're screening for hereditary cancer and things to collect before a healthcare appointment is we're interested in the type of primary cancer in each relative. So where the cancer started. A lot of times people report where the cancer spread to or metastasized. So for example, we often hear my grandmother had bone cancer. Well, bone cancer is fairly rare, but a lot of cancers unfortunately spread to the bone, and that's where someone may ultimately pass away from that disease. But we want to know where it started as opposed to possibly where it spread. The age of cancer in each relative. So again, because certain cancers can recur, we want to know when that cancer first developed in your family member. It's important to know cancer status in first-degree relatives, so that includes your siblings, your children, your parents, but also in second-degree relatives, aunts, uncles, grandparents. The more information, cousins, great-grandparents, we're just going to be able to make a better risk assessment, particularly if you have a small family where you maybe don't have a lot of extended second-degree relatives. The more you know, we can just make a more accurate assessment. And it's important to note cancer on both sides of the family. This is still a lingering misconception, particularly when it comes to female cancers like breast and ovarian, that you can't inherit an increased risk from your dad's side. That's not true. We're half our mom, half our dad. So it's important to note cancer history on both sides of the family. So this is just an example of a family tree or a pedigree. So squares are males, circles are females. Any individuals shaded in means that they've been diagnosed with some type of cancer. So if we look at this verbally reported pedigree, we see a man coming in because his mom had stomach cancer, sister had bone cancer, there's a prostate cancer. Well, this is a family that isn't strikingly suggestive that it could be hereditary. But upon finding out more information, well, his sister didn't have bone cancer. She had breast cancer at 45 and eventually passed away from her disease in her late 50s. And mom didn't have stomach cancer. She had ovarian cancer. So this went from a low-risk family to finding accurate information to a high-risk family that would be very appropriate for a genetic workup. Another issue that we find often when patients are reporting their family history is a lot of times people will report, well, she had female cancer, and that could be lots of different types of cancers, and not all of them we're concerned about as a red flag. We also hear a lot of abdominal cancer. Again, that could be many different types of cancer. So the more you know about your family history, about the types of cancers, the ages, again, it's going to be a better assessment for you. And particularly if you report the wrong information, you might not get flagged or referred for genetics. Another highlight is family histories change over time. So each time you go to your healthcare provider, you want to update them with any family history, even if you just make the phone call and update your chart. So we have here a woman comes in because her mom had breast cancer in her mid-50s, maybe not referred for genetics, but then 2 years later, her sister was unfortunately diagnosed. So again, went from maybe not referred to a referral is absolutely appropriate. But if you don't report that family history, that referral may not be made. So overall red flags for hereditary breast and ovarian cancer. So for the purpose of this talk today, I'm really focusing on more of the common types of cancers, common referrals, but we see in our group referrals for any type of cancer. So some red flags for breast and ovarian is typically early onset breast cancer, so often before age 50, although some groups, the American Society of Breast Surgeons, do recommend genetic testing for all women with breast cancer, no matter what age. Ovarian cancer at any age, male breast cancer at any age, pancreatic cancer at any age. So it doesn't matter if those three cancers are in the 40s, in the 90s, it's a red flag, it's an indication for genetics. We also know prostate cancer can be hereditary as well. And those tend to be the more aggressive prostate cancer, so metastatic or very high grade. So it's important to note in your family history, if you've had a relative pass away from prostate cancer, that's important to let your providers know, as that's an indication for genetics. Again, we talked about Ashkenazi Jewish ancestry is at a higher risk for hereditary breast and ovarian cancer. If you have a mutation in your family, obviously we want to evaluate you. And if you have a family history, so unaffected, but multiple relatives with breast, ovarian, and pancreatic. So the most common breast and ovarian cancer genes, and these are the ones that most people have heard about, BRCA1 and BRCA2, so they stand for breast cancer 1, breast cancer 2. Everybody has these genes, so everybody listening to this webinar, they're good genes. Their job is to protect us from developing cancer. What we do in a genetic test is not to see if you have those genes. We know you do. We're looking to see if those genes are working properly. And if someone has a change or a mutation, they are at a high risk to develop certain types of cancers. So the lifetime risk for BRCA carriers, if you have BRCA1 or BRCA2, for women, it's a very high risk for breast cancer, almost up to 80% lifetime chance. Ovarian cancer can range between the two genes, around 10 to 20%, almost as high as 50+% with BRCA1. A lot of people think that the men in the family don't need to be evaluated for this, and that's incorrect. We do know that there's a high risk for male breast cancer, as well as prostate cancer, and we can also see an increased risk for pancreatic, as well as melanoma. So how do we follow someone if they're positive? If someone has genetic testing, our entire goal of that test is to prevent a cancer from happening, or at least catch something as early as we possibly can. So we come up with a game plan in terms of surveillance, maybe even preventative surgeries, again, with the goal of prevention, or at least early detection. So if someone tests positive for hereditary breast and ovarian cancer syndrome, typically we recommend clinical breast exams twice a year, and we follow individuals with mammogram, 6 months later breast MRI, 6 months after that mammogram again. And we may start the breast imaging as young as 25. We can do some internal ultrasounds, some blood work for ovarian cancer screening, as well as pancreatic cancer surveillance. So we do have a high-risk pancreatic screening program at Atlantic Health, and it's a way for some higher risk individuals to have their screening within our healthcare system. Some individuals may be eligible for chemo prevention. So typically it's a pill that you can take to lower your risk of developing cancer, and that needs to be discussed with your physician. Some individuals may choose preventative surgery, so prophylactic mastectomy or removal of the breast. And in general, we do typically recommend removal of the ovaries because our screening for ovarian cancer isn't very effective. Mastectomy is a personalized decision. Some people choose it. Some people choose increased surveillance. There's not a right or wrong. It's what's right for that individual. But removal of the ovaries, that typically is a recommendation. So switching gears to colon cancer. Again, those same numbers apply that I reviewed at the beginning. It's a small portion that's hereditary, around 5 to 10% roughly. But with GI cancers or colon cancer, we can see more of this familial tendency, because we know GI cancers can be linked to diet, to exercise. So this is where some families, we see a bit more GI cancers. Doesn't mean it's a single genetic change. It could be this combination of low risk genetics as well as lifestyle and environmental factors. So last summer, it was recommended from the National Comprehensive Cancer Network for genetic testing to be considered for all patients with colon cancer, regardless of their age of diagnosis, regardless of their family history. So this was a really big change that happened just last summer. Prior to that, we were really only offering testing to individuals who were young, who had a strong family history, maybe multiple cancers. So this was a kind of a big update in my world last summer. So what they found is, in really large studies looking at colon cancer patients who were deemed high risk from our prior criteria versus all comers, it's almost the same positivity rate, around a 9+% for all patients with colon cancer of us finding something. And then in younger individuals with colon cancer under age 50, it was almost as high as 16%. So if you've had colon cancer in the past and maybe someone said, nope, you don't meet criteria for genetics, you're low risk, might be something you want to revisit or rediscuss with your providers. So some of the more common referrals for hereditary colon cancer, even though it's now a consideration for all comers, is we still typically see individuals who have a younger colon cancer or a family history of early onset colon cancer, multiple GI cancer, so colon and stomach, small intestine. One of the other referrals that maybe individuals aren't as aware of is sometimes we see patients not because they've had cancer, but because they've had multiple colon polyps. So anytime someone hits 10 colon polyps over their lifetime, and that could be 10 polyps in one colonoscopy, it could be 5 in one, 2 in the other, 3 in the next. Anytime you hit that magic number of 10, genetics evaluation is indicated. So the most common form of hereditary colon cancer, as well as hereditary uterine endometrial cancer, is a condition called Lynch syndrome. And Lynch is the name of the physician who classified it many years ago. It's historically called HNPCC, but that's a mouthful to say, so Lynch syndrome. Individuals with this typically develop colon cancer at very young ages, more in their 40s, but we can see it at any age. These cancers tend to be on the right side of the colon, so it may say on the pathology report ascending colon. And we can see many other types of cancers, so endometrial, ovarian, stomach, urinary tract, bladder, small bowel. We can also see very distinctive type skin cancers called sebaceous skin tumors. So sometimes we get referrals from dermatology as well. So here at Atlantic Health, we've been doing special testing on individuals who have colon cancer surgery here or other types of cancer surgeries to give us some insight whether or not they have Lynch syndrome. We've been doing that for a number of years, just gives us some insight as to who should be flagged as possible genetic workup. So how do we handle individuals who are at a high risk? Well, if someone's at a high risk for colon cancer, we're going to do colonoscopies at a younger age and generally go more frequently. So most people may have a colonoscopy every 5 to 10 years. If someone's at hereditary risk, we may need to have a colonoscopy every 1 to 2 years. Often things are sped up, so we can go from a normal colon to a polyp to an advanced cancer at a much higher rate or incidence, so we need to screen them much more aggressively. But colonoscopy is one of the tools that can prevent a cancer. Most other screening just hopes to catch it early. If someone's at risk for gynecological cancers, in addition to screening, it could be an indication, and it often is, to have a preventative hysterectomy as well as removing of the ovaries and the tubes. For some of these lesser risks, like urinary tract, bladder, we may do a urine test once a year. So things to think about before genetic testing. Well, who in the family is the best person to test? In the ideal world, we want to test someone who's had cancer in the family, and typically the youngest person who's had cancer in the family. But that's not always an option. Sometimes people have passed away. Sometimes family members say, nope, I'm not interested. I don't want to know. And so we certainly can test individuals who are cancer free. What genetic test should be ordered? And there's lots of different options when it comes to cancer genetic testing. And typically it doesn't change the cost of the test the more cancer information we get. So we can tailor it to someone's family history. We can do more of an actionable test looking at all different types of cancers, but cancers, genes that come with guidelines. If we find something, we know exactly what to do. And then we have your go all in, go big, go home test that generally looks at everything from an actionable side, but adds on up and coming genes. So genes that we may not have the full story just yet, but maybe we will next year or the year after that. And the family and the patient has banked that information for future use. What would positive results mean for me and my family? So if someone's positive, it's important to note that it doesn't mean cancer's lurking there already, doesn't mean cancer will definitely happen. It just means someone's at a higher risk to develop cancer over their lifetime. In general, how these cancer syndromes work is if someone's positive, typically their first degree relatives, so their siblings, their children, their parents are at a 50% chance to have that same genetic marker. So it's like a flip of a coin for these relatives. So we do recommend what we call cascade testing, testing other family members, again, to figure out who's at risk and who's not. What would a negative result mean? And sometimes people think, oh, I tested negative, I'm off the hook, I'm never going to develop cancer. And that's not the case. It just means we've ruled out that hereditary portion. We're still left with what's going on in the family, and it could be sporadic, it could be something we have yet to identify. So a negative genetic test result really just helps us put in perspective someone's risk. It doesn't get them off the hook. Cancer can still develop, and we still need to follow someone based on their family history. Could the results be uncertain? And yes, there's a third possible outcome with genetic testing. It's called a variant of uncertain significance. It's a change in a gene that we're just not sure what it means, if it's linked to cancer or benign. These are really common, particularly when you go big in your testing. In general, they're much more likely to be downgraded to negative than upgraded. So often we follow them in the negative pile. We don't do anything differently for a patient based on that. What impacts could the results have on me and my family emotionally? Do all family members want this information? Could this strain relationships or communication in the family? So it's not just a simple test, and it's not a test just for that person taking it. It has an impact for their children, for siblings, for extended relatives. And not everyone is going to want to know this information. So some people really embrace genetic testing and want to know so they can be proactive. Some family members could say, I don't want to know anything, and I'm upset that you even shared that information. Also, you can have family members where, say, one sister chooses preventative mastectomy, the other sister chooses screening, and they differ on those, on their management choices. So genetic testing can cause a strain in relationships and communication. And we're here as a resource to talk patients through that. We do encourage patients to share genetic test results with their family. Again, we don't want a cancer to happen in another relative that by sharing that information, we would have had a shot to prevent that from happening, or at least catch something as early as we can. There's different ways to share genetic test information. It doesn't have to be in person. Sometimes it's just sharing a letter or an email or making a phone call. There's various ways that people can share this information. Could my family or I be discriminated against based on these test results? And the answer is yes and no. So we'll go into this in more detail, but we do have laws that protect people against genetic discrimination, but it doesn't cover all aspects of insurance. So there's different laws for health insurance versus no laws for things like life insurance, long-term care. Will insurance cover genetic testing? In general, if someone is at high risk and they were referred for genetic counseling and testing, there's a good chance we could get it covered by insurance. And the coverage for genetic testing does change over time. So for example, if a lot of you are Atlantic Health, Aetna just made a big change in their criteria for the better in January. So just because someone wasn't covered in the past doesn't always mean they wouldn't be covered now or in the future. But genetic testing a lot of times is covered by insurance. And how can I use this information in my medical care? Again, the goal is prevention, early detection, not just for the patient taking the test, but for their family members as well. So if someone were to test positive, we generally outline their surveillance moving forward and pass that along to their healthcare providers to implement the management. And it's important to note that sometimes based on someone's age, we may not act upon this information, but maybe at a later date we would, and different risks may kick in at different ages. And so we may need to modify their management as they get older, as they approach key ages where those risks start to develop. So I've talked so much about genetic testing, but what is a genetic test? It's generally blood or saliva. So it's just a way of us getting patients' DNA. So for a saliva sample, sometimes it's people literally spitting in a tube. Sometimes it's a cheek swab. There's no difference between the two. Your DNA is your DNA everywhere. It's just where we're accessing it. So essentially, you can think of genetic testing as we're reading really long books and looking for a spelling mistake. We're reading our genes to see if everything is in order. If we find a spelling mistake or a change, it's essentially a mutation. That gene isn't working properly and it's putting someone at a high risk to develop cancer. So possible test results, we have positive, we found something, and then we have a discussion about management, not just for the patient, but next steps for their family members. It could come back negative. If it's negative, you're followed based on family history. And if it's negative, it could be there's nothing going on. Or it could be we just didn't test the appropriate family member. Maybe there is a mutation in the family and the patient who had the negative test just wasn't the right person to have that test in the family. Third result is called that variant of uncertain significance. Again, we just need more time to figure it out. It's a gray zone area, but in general, these typically get downgraded to negative. So I've talked about BRCA and Lynch syndrome. Those are the most common cancer syndromes for breast and ovarian, as well as colon and uterine, but those are not the only conditions we test for. Starting around 2013, so we're coming up on the 10-year mark, a new type of testing came out called multi-gene panel. It's just the technology advanced so that we could look at multiple genes all simultaneously in one test. So for instance, if we have a woman with breast cancer in the family or her own diagnosis, there are around 20 genes that we can test for. So we don't just look at BRCA. We can go much bigger in our testing. Our current testing, we can look at over 100 cancer genes. So we can go really broad in our analysis. Some of these genes are really high risk. Some could be moderate risk. Some could be low risk, where maybe it's around a 5–10% chance of developing cancer. And each gene generally has its own set of management recommendations. Panels vary by lab. So it's not to say if you went to lab X, it would be the same exact test as lab Z. Each lab generally has its own platform, its own types of genes they test for. Maybe cost could vary. But importantly, cost and insurance coverage could vary by lab. So some insurance companies are in network with certain labs and out of network with others. Years ago, when I started genetic counseling in 2005, testing was about $4,000, and it took roughly around 6 to 8 weeks for us to get a test result back. Now the out-of-pocket expense for most labs, most really good quality labs, you're looking at a self-pay price of around $250. So we went from $4,000 to about $250 out of pocket. So that's if you choose to do self-pay without going through insurance. And test results generally take around 2 to 3 weeks to come back. So it's a massive difference from just years ago. So that's also important to note. If you weren't covered in the past, doesn't mean you're not covered now. Or say if you had BRCA testing years ago and you were negative, you might want to be reevaluated with our updated testing. So there's different things we can look for in these expanded panel tests. Again, we have high risk genes, so genes that are well established. We've known about them for a long time. We know really how to handle them. You have moderate risk genes that could be a combination, again, between that genetic factor, but sometimes it can vary. Your level of risk could vary based on your family history. So we may need to tweak some of our recommendations. And then we have preliminary evidence genes. So again, genes that as of today, we may not know the full story. We need a bit more time, but maybe we'll figure it out in the near future, and you've just banked that information. It's important. Some of the genes we previously thought were at an increased risk for cancer, and then we got more information and said, nope, we were wrong. It's not associated with an increased risk. So things can change in the other direction. That's very rare, but it has happened. So genetic testing, again, is not just a simple test. Positive results can have limited information. We can have inconclusive results. So we just don't know what's going on, even in families where our gut tells us there's a genetic factor. We also find, and this is much more often than we previously knew, results that don't fit. So someone comes in for colon cancer testing, we find a mutation in a breast cancer gene, or someone comes in for breast cancer testing, we find something in a thyroid cancer gene. So we do find these unexpected mutations. And that's why we do discuss broader based testing with our patients, at least here at Atlantic Health, because we don't want to miss anything, at least something that's actionable that we can be ahead of and find out about. For a lot of individuals, genetic testing causes, rightfully so, worry and anxiety. But it is something to talk through, and some people may ultimately choose after our consult, it's not right for me, I'm not interested, or some people will say I need a bit more time and I'm going to talk it over with family members, with friends, and then they can always come back for the test if they change their minds. It's important to note that a negative result in an unaffected person, so someone without cancer, really means nothing if there's a significant family history, because it could be something's running in the family and the individuals with cancer have something and the healthy cancer-free patient just did not inherit that mutation. So again, we still need to follow based on family history and try to test affected members if possible. So I alluded before, but what is genetic discrimination? So a lot of people are fearful of genetic testing and don't come in, or have been referred and don't wish to pursue it because they have a fear that this information could be used against them. We do have federal laws that protect people against health insurance discrimination, as well as employment discrimination. So essentially it can't be used to drop someone or raise someone's rate, drop their children, their dependents based on the information. We have no protection for things like life insurance, long-term care. So really more of elective insurance is outside of health insurance. So it's part of our conversation with our patients prior to doing a genetic test, and some people may wish to get some of those things in order before having the test itself. It's not routinely happening that people have an issue with their life insurance after genetic testing, but it can be, and we have nothing to protect you if that were the case. So who are genetic counselors? And here at Atlantic Health, we're a team of 3 cancer genetic counselors. We do have prenatal genetics, cardiac, adult onset genetics. We have a robust genetics in place at Atlantic Health. I'm obviously part of the cancer genetic team. So we're health professionals with specialized graduate degrees. We're not physicians, and we have experience in medical genetics as well as counseling. Most of us enter the field from biology, from genetics, nursing, psychology, a wide range of different backgrounds. So if you or a family member or a patient of yours chooses to come in for a genetic consult, really it's more of a conversation. So we go over someone's medical history, their family history. We draw up their family tree. We talk about what could be going on in the family. We do a risk assessment, and sometimes people come in and we say, you are really low risk. We still offer genetic testing if someone's low risk. We're not a barrier to the test, but sometimes it could be reassuring to put into perspective your perceived risk versus your actual risk. We talk about genetics, natural history of what we're concerned about, your options for management and surveillance, risk reduction if you were to test positive, really, so people are informed going into the test what could be the outcome of the test. Review of risk benefits, limitations of testing, and provide referrals and identify resources both within the community as well as different online resources or national groups for individuals at hereditary risk. So in summary, you can consider cancer genetic counseling or ask your physicians or your healthcare providers for a referral. If you have a personal or family history that could be suspicious of a hereditary cancer syndrome, or even if you just have anxiety about the cancer in your family. Again, not everyone who comes in to see us, we're going to tell you you're super high risk. Sometimes we can actually give you some type of reassurance that you're lower risk if we talk about red flags. Just to mention too, we see a fair amount of patients who are adopted, who know nothing about their history, know nothing about their family history, but are still interested in a cancer genetic workup to get some information. So we're happy to see those patients as well. If someone has had a negative genetic test in the past, pretty much anyone evaluated prior to 2013, likely 2014, needs to be reevaluated because that's when we had a major shift. But even some genes that we look at, we've only known about for a handful of years. So if you have a genetic provider, you can always get in touch with them to see if there's any new updates that may apply for them. So in conclusion, identification of high-risk families is really essential to prevention. Again, I know I said it a bunch of times, but the goal of genetic testing is prevention as well as early detection. We want to use this information so that the family history of cancer doesn't keep repeating itself. If we know what we are at risk for, we can take steps to mitigate that risk. Referral to genetics can provide valuable information for your patient, but also for their family. And we're a good resource in helping patients share that information and come up with ways to share that information. So sometimes we may see people who were tested in the past, and now it's time for them to share that information with their children. And we may just have a conversation. They may come back in to see us, not from a medical standpoint, but just, how do I share this with my daughter who's 18 and may need to get tested soon? How do I share this with my son? How do I share this with my family? So that they are best prepared to handle this information, or that I am best prepared to share this information. So ultimately, genetic testing is a process. It's complex. It has lots of implications, not just for the patient taking the test, but for their family as well. So here at Atlantic, we have 3 board certified licensed genetic counselors in cancer. We all specialize exclusively in oncology. We see patients at Overlook, at Morristown, at Chilton, at Rockaway. We do need a referral or a script from one of your providers for that appointment, and patients are always referred back to their physicians for management and follow-up. And here's my number at the bottom if anyone were interested in scheduling an appointment in the future.